I'll be presenting 3 points in this 15 minutes. Thank you, Dr. Ross, for that introduction. We have the prothrombotic mechanism of stroke in COVID-19, how the pandemic has affected our acute stroke management, and a call to action on how to recalibrate our hyperacute stroke management during these difficult times. So let's first discuss the prothrombotic strokes. So a systematic review by our very own Dr. Collantes, Espiritu, Anlacan, and Jamora showed that among patients with COVID-19 presenting with neurological signs and symptoms, the top neurological disorder is still the strokes. Take note, they had 33 patients for several studies. And among those strokes, a lion's share was due to ischemic strokes, as you can see here, which can be attributed to a prothrombotic state. Now, this deserves more than 15 minutes to discuss, so we will just go to the take-home messages here. What's known so far for prothrombotic states in stroke is immunothrombosis. So here on your screen is the end product, the clot of fibrin. So it's a product of thrombin. What's the connection with the SARS-CoV-2 virus over here? It enters the ACE2 receptors, and in our case, the endothelial cells are the culprits for strokes. So patients with COVID-19 will have a lot of inflammatory cytokines. The increase in interleukin-6 is associated with increased fibrinogen levels. So our infected endothelium is dysfunctional, so it follows a different pathway aside from the inflammatory cytokines. So increase in tissue factor leads to thrombus formation. Now, SARS-CoV-2 may be considered a perfect stroke-causing virus because of the several pathways it activates. So the fibrin itself can release inflammatory cytokines. We know that because we have elevated C-reactive proteins in acute strokes, which in itself can be very damaging. The recruitment of our immune cells. You have our neutrophils with their extracellular traps. At the same time, in this picture, we see due to the involvement of the renin-angiotensin system, which is dysregulated, which can also cause vasoconstriction and is also prothrombotic. And the remaining immune cells that are involved is the macrophages, which will upregulate tissue factor, which will produce even more fibrin clots. The dysregulated complement activation is also implicated in strokes in COVID-19. So to sum it up in 2 bullets, there is endothelial damage or endotheliitis in SARS-CoV-2 infections, which leads to thrombosis. And the thrombosis itself can incite an inflammatory response. So it's bidirectional and disastrous. So what can we do? What have we been doing in PGH? If they do come within the therapeutic window of 4.5 hours, we thrombolize our patients who are eligible for RTPA. For those who come in beyond the 4.5 window, we also start low molecular weight heparins. It has been shown that the COVID-19 patients will still have VTE events despite being put on low molecular weight heparin. So we would push for higher doses of low molecular weight heparin. If they have the risk factors for stroke, and we will go into this a while, we start antiplatelets. If they are cardioembolic, we give anticoagulants. So some cautions with our antiplatelets. If you're giving immunotherapy, your ritonavir or lopinavir, there will be some drug interactions with your clopidogrel and prasugrel. Okay, as mentioned earlier, if they have valvular heart disease or they are presumed to be cardioembolic infarcts, we start them on anticoagulation. Some caveats though, you cannot give DOACs, or you have to give DOACs with caution because they also interact with ritonavir, lopinavir, and hydroxychloroquine. So they potentiate the effects of the DOACs. Okay, so several drug interactions with the immune therapy with DOACs. Also, we have to watch out for prolonged QT interval if we do use apixaban together with hydroxychloroquine. But we must treat the COVID because it is an immunothrombosis, a prothrombotic state due to COVID-19. Now, as it has been mentioned earlier, since April, we've been designated as a COVID referral center, and we pushed for all our stroke patients to be swabbed first for COVID-19 before we admit them, which bore fruit. As you can see here, majority of our COVID stroke patients were the ischemic strokes. A far second are the intracerebral hemorrhages. Okay, so remember that systematic study by Dr. Collantes, which had 33 patients over 14 studies. In PGH alone, we had 33 COVID-19 strokes referred to our neurology service. So for our incidence for COVID-19 patients, all strokes 2.4%. The incidence for ischemic strokes was 1.7%, which is really close to the numbers from Wuhan and more than that seen in New York. So the question we should ask ourselves, should you test acute stroke patients for COVID-19? Will you or will you not? The next slide will answer this. Among our patients who came in for COVID stroke, for only 60% were symptomatic for the fever and respiratory symptoms, meaning nearly 40% of our patients were asymptomatic for COVID-19 in terms of the respiratory symptoms or fever. So you should consider testing your acute stroke patients coming in the emergency room. Another way to look at this, the proportions for our ischemic strokes admitted in our hospital, 60% were COVID positives. So a major proportion were COVID positive. Now, Claire showed you our patient earlier. So these are the range of the ischemic stroke manifestations. It can range from small vessel disease to large artery disease. In extreme cases, a bilateral ICA infarction was one of the patients that we managed during this COVID pandemic. Okay, so breaking down our ischemic strokes. So majority were presumed to be large artery atherosclerosis. We had distant second, the cardioembolic strokes. Comparing this with our COVID negative ischemic strokes, which is the pattern we've had for a while, most of them were cardioembolic. So these were the COVID negative patients coming in from April to August. Going to the demographics, a very significant proportion of our ischemic stroke patients, actually all stroke subtypes, were the males. So 80% were males. Okay, as to the age distribution, our patients were mostly 58 years old. The COVID positives were slightly older. So 60.5 years old compared to 53 years for the COVID negative patients. I summed up the stroke risk factor profiles of these COVID-19 patients. Majority were hypertensive. And it seems that hypertension really is a very strong risk factor for stroke, and even more so with COVID-19 strokes. Diabetes mellitus was not so much a factor in the COVID-19 stroke patients. So patients who are male, hypertensive, obese, and diabetic, the so-called metabolic syndrome, are already at high risk for endothelial damage. So it seems that COVID-19 pushes them more to develop a stroke. Now, what was the effect of the pandemic on PGH, stroke management? Another question you would ask yourself, would you thrombolize an otherwise eligible hyperacute ischemic stroke patient whose COVID-19 test has not yet come out? Would you? Or would you wait before you thrombolize these patients? The answer is no. So comparing with our neighbor in Hong Kong, so I got this study from Hong Kong. the effect of the pandemic on their side. So from 72%, there are patients who came in within the window for thrombolysis, went down 20%. What happened in PGH? I'll show this later. So for that center in Hong Kong, they made up for the patients coming in late by being faster with the way they gave their thrombolysis. As shown earlier by Dr. San Jose, this has been our pattern of our brain attack calls, a very significant decline in patients who come in on time and referred to the stroke service. So this corresponds to the GCQ over here. Okay, so the proportion of patients thrombolized also diminished. So these were in blue are those who were thrombolized. As you can see, the decline over time is normal. They're usually majority in December and January, then it declines. But here, very little of our patients were thrombolized. There were only 3 patients thrombolized, including the one presented by Dr. Enriquez. Okay, so these were the numbers from Hong Kong. We just superimpose our numbers on top of it. So pre-COVID, we had a very good thrombolysis rate of 30% of our ischemic stroke patients, comparing that comparable with the Hong Kong, okay, where they thrombolized 15%. So we were actually doing better than Hong Kong, at least for this center. But with the COVID-19 pandemic, our thrombolysis rates went down. So take note, this means over ischemic strokes. So only 3 ischemic strokes were thrombolized. But the another denominator here is eligible patients. So all 3 were eligible patients. So we 100% thrombolysis rates. So our timelines in stroke, the door-to-bat times increased from 5 minutes, which is very good compared to the benchmark of 15 minutes or less. It increased to 13 minutes, but we're still within our benchmarks. How about the door to CT scan times? This is where the delays were added. An additional 30 minutes was added to our door to CT times due to logistical issues with the CT scan machine. So way over the benchmark of 25 minutes or less to do a CT scan. What about door to needle times? Pre-pandemic, it was 48 minutes, all in all, from the door to the needle. But during the pandemic, we added almost 50 additional minutes of delay to our door to needle times, way over the 1 hour benchmark. So just showing you logistical issues such as wearing PPEs, recruiting the utility workers to bring patients to the CT scan machine, and getting the patients to a ward where they can be monitored properly when we administer thrombolysis. So what were the outcomes of the 2 thrombolized patients? This was the patient that Dr. Enriquez presented. The outcome was poor, but the cause of death was due to the COVID pneumonia, a very low ejection fraction. The other COVID-19 patient who was thrombolized survived. So very good outcome. Although it was a small vessel disease, the baseline NIH stroke skill score went down from 8 to 1. Discharged, improved. So what were our mortality rates? So comparing the COVID positives with the COVID negatives, the mortality rates were higher across all stroke subtypes. Putting it into perspective, the cerebrovascular disorders accounted for 7% of all of our COVID-19 deaths as of last week. Okay, teasing apart the different stroke subtypes. So we see that the large artery occlusions accounted for almost 60% of mortality rate. So ischemic strokes accounted for 5% of all COVID-19 deaths as of last week in PGH. Okay, so just showing you the breakdowns. In terms of the cause of death, majority were still non-neurologic, mostly due to the COVID pneumonia complications, which were, number 1 was sepsis, number 2 was the respiratory failure from the severe COVID pneumonia. Only 3 were neurologic in nature, and 1 was due to a possible acute coronary syndrome. So how do we recalibrate our response? A single member of the stroke team may be designated to stay there in the emergency room in their full PPEs and stay with the patient until they bring them to the CT scan machine. This is Dr. Weng Halipa. We owe much of the data to him for COVID-19 strokes. The use of telemedicine. So Dr. Rojas can contact Dr. Astejada and Dr. Moalong in the ER. You can see him perform the NH stroke scale score, or people in the ER who we can designate. Now, there is a strain on the initial few months of the COVID pandemic on all specialties in the hospital in PGH. So the realignment of the different specialties to care of COVID-19 patients that should have been dedicated to acute stroke. So the skeleton crew was a factor as well for our mortality rates. Okay, so we should continue to take care of our non-COVID medical emergencies such as stroke. That is our call to action, because having COVID does not mean you will not develop a stroke. Okay, acute stroke patients must continue to have expedited access to the CT scan machine. This is a perfect world scenario where they have dedicated CT scan machines for COVID. For the COVID suspected, a separate machine for the confirmed COVID cases. But this is just wishful thinking on our part. Okay, showing you that full reprogrammed stroke pathway. Once they've called the brain attack, those who are not confirmed to be COVID negative follow this pathway. They are seen by our healthcare workers in full PPEs, and they are funneled through a separate CT scan machine depending on their confirmed or suspected COVID-19 status. So for our residents and fellows, they follow this full PPE checklist. All of them are carried out. Okay, that's the full pathway, just focusing on this part of the screen. Where possible, telemedicine should be used for our IV thrombolysis. So take-home messages, again, 3 of them. Ischemic stroke in COVID-19 patients are due to an inflammatory cytokine-mediated prothrombotic state. So we should see the whole picture when we deal with our patients. We treat the COVID, at the same time we give our antithrombotics. Patients who come in within less than 4.5 hours should still be given thrombolysis. Otherwise, we consider giving higher dose low molecular weight heparins and start them on the appropriate antithrombotic. So a dictum during the early parts of the pandemic was there was no emergency during a pandemic, but our final reminder to everyone is stroke is still an emergency even in a pandemic. So thank you very much.